I'm Dr. Karatas. I am Karatas. I will talk about testosterone replacement therapy, more medically known as androgen replacement therapy, RT. Now, I've already talked about this part a lot. Let's briefly go over it. A hormone is released in a part of the brain called GNR. In another part of the brain, FSH and LH are released. FSH was responsible for producing sperm. LH was responsible for producing testosterone. I've explained this in almost every video. Now, low testosterone is referred to as hypogonadism. Of course, when do we perform ART, that is androgen replacement therapy? We perform it if the problem is here. So we perform it if there is a problem with the testosterone production in the testes. If there are issues here, then we want to solve the situation in another way. For example, when we do a test for this, once I explained this in detail in a video to identify the situation, we do these to test. If we see that total testosterone is low and FSH, the stimulating hormones, are high, then the problem is here. This is where we perform testosterone replacement therapy. But if testosterone is low, and these are also low, or if these areas are low, then the problem is here. Then we need to do other things. We need to investigate. So, in the end, I identified it. Testosterone is low. The first thing I will say, I always say the same thing, but if a person has low testosterone and have decided on testosterone replacement therapy, then it means this person will probably need to use it for life. That's why there's no joke about this. The medications need to be adjusted seriously, and as I will mention shortly, there needs to be serious monitoring. Now, there are 3 forms of testosterone intake. Of course, we don't take pure testosterone. What are we doing? We take substances called testosterone esters. It can be taken orally, injected into the muscle, or applied on the skin. What is the most commercially used form of testosterone on the skin in the world? Doctors usually start with intramuscular injections at the initial stage. The oral use is almost non-existent, or in very few special cases, it can be taken orally. Now let's start with oral intake one by one. There are 2 major issues with oral use. One is to take it continuously and regularly by mouth. I mean, just think about it. You are 30 years old or 40 years old. For the rest of your life, you will be taking testosterone for 30 years. And you will take 2 or 3 of these every day, in the morning, at noon, and in the evening. This is a serious issue. And when taken orally, it will go to the intestines, be absorbed from there, and mix into the bloodstream. The liver needs to function and metabolize these medications for them to be effective. That's why it has some effects on liver functions. For this reason, it is not preferred much. Also, its stability is not very good. So, when taken 3 times a day, it may not be very well regulated. Testosterone undecanoate can also be injected into the muscle. This can be done. The advantage of this is 3 are taken a day. Yes, that's the disadvantage, but it doesn't have an effect on liver functions. But as I said, using it continuously 3 times a day is problematic. The most preferred medication for intramuscular use, meaning the one that's commonly chosen as a starting point, has a short form. There is also a long form. Now, what we call the short form is this. What we refer to as the short-acting form, it's done from the hip. After 2 weeks, some people need to do it again after 10 days, while others may need to do it again after 3 weeks. We're trying to adjust this dose a bit through trial and error. The long-acting one is administered. It's done again after 3 months. Of course, there's also some fluctuation with the short-acting one, because you're doing it, for example, what you do today, you'll do again in 2 weeks. So testosterone levels drop significantly towards the week. You do it again and it rises again. So there's such a fluctuation situation. With the long-acting ones, there is no fluctuation. You're doing it and it remains effective for almost 3 months. But there's a problem like this. Side effects. When I take this small testosterone, some side effects may occur. I'll talk about it shortly. There could be hormonal changes. Testosterone levels may increase and blood values may rise. For example, something like this comes up a month after you've done it. You have no chance of taking this back. Since you can't take back the medication you've administered, you need to manage these side effects for 3 months. That's why it's long-acting at the beginning. Starting long-acting testosterone from the hip is not a very correct approach, because we don't know whether there will be side effects or not. Over time, we looked at what we did, whether we use short-acting or gel. There aren't many side effects. We looked at the follow-ups, and then we can switch to 3-month forms in between. Yes, it is the most commercially used on the skin in the world. What are the advantages of these? Actually, there are patch and gel forms. It's not very important. Both are used once a day. We achieve a stable testosterone level with these. So, when we apply the gel or stick on the patch, our testosterone levels stay consistent. This is a huge advantage. Yes, skin reactions can occur, especially with patches. Gels can do this, much less. And because it is absorbed through the skin, there isn't a big issue, especially with the hormonal function tests. But what's the problem? You need to use it regularly every day. You need to stick it on every day. You went to the board, you went into the sea, summer came, winter came, etc. This can seem like a disadvantage in terms of usage. Now, he said there's no joke about this. When we start someone on testosterone, yes. When we say your tests aren't working and you need to use testosterone, they will have to use it for life. So there is a follow-up for this as well. So it's not just about saying, take this medicine, go. What are we doing? So at the beginning, we do a hormone test once a month. We check the PSA, which is an indicator of prostate cancer, every 3 months. We monitor kidney function tests. We check the blood values, including hemoglobin and hematocrit, because they can significantly increase blood values. We do blood lipids and cardiology tests once a year. So actually, here's how it is. To get started, we need these tests. To continue, we need these tests. So PSA, hemoglobin, hematocrit, and so on. Of course, doing these every 3 months for a lifetime can be a bit challenging. Of course, we don't do it that way. We do like this. First, we usually do a hormone evaluation after 1 month. Of course, we give testosterone and then we check how it's going. Is it increasing, decreasing? What's the status of the FSH medication? We're looking into these. Then, once it stabilizes at a certain level, we start checking every 3 months, then switch to every 6 months, and eventually go to once a year. We found we don't have any major side effects. The hemoglobin and hematocrit levels didn't change, and the kidney function test didn't change either. So then we switched to every 6 months and then to once a year. But initially, for the first year, it needs to be monitored very closely in terms of side effects and hormone profile. So, for example, this short-acting, you gave it from the hip, for example. You gave it twice within a month. In the first month, you definitely need to check the testosterone levels. What did we do? It might have come in low. It might have come in too high. Then we can decrease or increase it. So this will be done with monitoring and under the supervision of a doctor. That's it for this part. In our next video, we will talk about the testosterone that athletes use to increase their testosterone levels, even though everything else they use is normal. We'll also discuss something called PCT, or post-cycle therapy. They do something called PCT, which stands for post-cycle therapy. We'll talk about that too. We'll wrap up our videos on the effects and side effects of testosterone like this. Thank you.